Good afternoon. Can everybody hear us? Yes. Wonderful. So good afternoon, everybody. Thank you for attending. We're just going to go through a couple of things, the housekeeping like usual. So we have changed platforms. So right now we're using Zoom instead of Adobe Connect. The same goes for as last time. If you guys would like to receive CMEs, please go ahead and announce yourselves on the chat. Or if you'd like to chime in over the phone, go ahead. If we call on you for any reason and you would not like to answer the question or don't know the answer, you can go ahead and tell us to pass or you don't want to talk. If there's any questions or if anybody's having any issues, go ahead and type in the chat box, or you can go ahead and email myself, Michelle Widener, or Kevin Whirling, and we can help you get on. So here's to join the conversation. This is a little bit different than what we had for Adobe Connect. So as you see on the screen, the computer video is, actually, hold on just a second. Not showing our.
It should be on there. It's right there. It's the second one over. So see where your mute button is?
Mm-hmm.
Then there's your video. They have the same screen. And you don't want to click that because then we won't see us.
Okay. I'm not showing. I can see this.
Okay, I'll go ahead.
Okay, sorry.
So thank you guys for being patient with us as
Yes.
we test our
Yes, thank you very much. This is our first session that we're doing on Zoom, so we kind of have a little bit of a learning curve, so please bear with us.
Hi, I'm Heather Pratt-Chavez. I'm a pediatrician at UNM Hospital in Albuquerque.
And I'm Ann Weingartner. I'm a neonatologist at Presbyterian Hospital here in Albuquerque.
And we're going to talk to you about care of neonates with prenatal opiate exposure. Our slides are going to be available for download later, and as soon as they get the system working, they'll pop up as well. So in the meantime, we'll talk through this topic without the slides. So we are happy to be invited by the New Mexico Pediatric Society and Envision to come and talk to you today. Also, we're supported by our departments, UNM Department of Pediatrics and Presbyterian Hospital Neonatology. The objectives of our talk today, we have three major objectives. First, we're going to review some of the population data about neonates with prenatal drug exposure, both nationally and locally. We're going to talk about the acute inpatient care of these neonates using what we know about their physiology and the pharmacology of neonatal opiate withdrawal syndrome. We're going to then introduce you guys to a really cool, exciting statewide initiative that we have with Envision and the Perinatal Collaborative to standardize the care of these babies and also offer opportunities to providers to earn maintenance of certification and participate in a quality improvement project. So I don't think I need to tell anybody who's a provider here in the state that we are the leading edge of a national public health crisis with the opioid epidemic problem. We all have cared for patients and infants who are part of this national crisis. We know the rates of neonatal exposure to opiates are increasing just at the same rate of use and morbidity mortality for adults. Okay, we have our slides going, so I'm going to yeah. Do you guys need to talk about this?
No, it's okay.
All right. And so these are some of the images that come up if you do Google images about opioid epidemic. A lot of people are talking about this in all areas of social media and the news because it's touching a lot of aspects of society. Here's kind of, I think, one of the most striking measures of the effects of this opioid crisis. These are drug overdose deaths in the United States, and it's almost quadrupled since 2000 through 2014. So, and most of these overdose deaths are driven by opioid deaths. We're talking about a special population of people who are suffering from the effects of this opioid crisis. It's neonates. And this is a slide that was generated by the New Mexico Department of Health. And this is the number of neonates who have a diagnosis of neonatal abstinence syndrome. And you can see that the red line is the United States. And so the latest data that we had was in 2012, and the rate was 6.1 neonates per 1,000 have a diagnosis of neonatal abstinence syndrome or opiate withdrawal symptoms. In New Mexico, of course, we're quite a bit higher. We are at 9.1 infants, neonates, born in the state carry the diagnosis of neonatal abstinence syndrome. And what's really interesting is that some of our counties have much higher rates than that. So in 2013, 39 babies out of 1,000 carried the diagnosis of NAS who were born in Rio Arriba County. That's the county with the highest rates. The next highest is actually Socorro County with 36. Taos County had very high rates at 24. So these are quite a bit higher than even the national average. So this is a real problem in New Mexico. When we're talking about best practices for care of these babies, I think it's really important to take a step back and make sure we're all talking about the same thing and using the right terminology. And I wanted to give you guys the ICD-10 code for this diagnosis. We should try to all use consistent terminology in our clinical notation because it will help with population data, and it will also help with billing and with complying with the new ICD-10 requirements. So the definition of neonatal abstinence syndrome that I think I really like is the one that was in the up-to-date article from 2014, that it's a variable, complex, and incompletely understood spectrum of the signs of neonatal behavioral dysregulation. And I think I would add in there that it's also physiologic dysregulation that's really driving the behavioral dysregulation. And babies with prenatal opiate exposure are really hard to care for. And I think one of the main reasons why it's such a challenge for especially providers of family and pediatric medicine is that we like preventative medicine. We feel really good when we're staving off an illness or immunizing a child. And there are so many points in this, care of these moms and babies that there could have been prevention, but there wasn't. So you start with a woman who has some inciting incident, maybe trauma in her life, maybe actual physical trauma or an illness. And then because of poor care or inadequate care, this trauma leads her into a substance use disorder. And right there is a big missed opportunity for prevention. Then once she has a substance use disorder, then we don't have means of good treatment in many places in our state, and treatment is very difficult to access for so many people. So she is missing another point of prevention there. Then oftentimes, if they're missing treatment for substance use disorder, they're also missing routine health care and, very importantly, family planning care. So another point of prevention missed. So then now we have a pregnancy on top of a substance use disorder. And there's another point of oftentimes where moms will fall through the system where they don't get good prenatal care, so there can be comorbidities of this pregnancy that are not addressed. And also, again, probably it's very hard for her to get adequate care for her substance use disorder during her pregnancy. So at the end of all of these missed opportunities, we have a baby with symptoms of opiate exposure. And it can be very discouraging to find yourself in that circumstance. Then we have this little baby who is suffering. These babies are just miserable and sad, and that's also very difficult for providers to care for them. So here we have these two people that we're trying to take care of, and we have this baby who is fussy. He's miserable, very difficult to make this baby feel better. And then you're providing care for this baby who's suffering because of what their mom was doing, and it makes you feel it's painful. And then there's also this other factor, back to the previous slide, where it feels like this illness could have been prevented at so many points, and we miss so many points. Then we also don't have great data of what the effects are of prenatal opiate exposure, and then we don't have great data about if our treatment actually makes any difference for these babies long term. And then right next to this little baby, we have this mom who's also suffering. She has a substance use disorder. She has the psychiatric comorbidities that go along with substance use disorder. Could be depression, anxiety, bipolar disorder. Really challenging personality disorders like borderline personality disorder often go with substance use disorders, and that can often put a lot of barriers to providing care. Then throw on top of those her postpartum changes that every mom goes through after they have a baby. And then these moms oftentimes have alienated or have really kind of cut off their social support networks because of their substance use disorder and are really missing productive social support in their community. Lay on top of that how much guilt they feel for what their baby's going through. Then this whole time they still have a lot of barriers to getting good care for themselves in this postpartum period, and so their substance use disorder is oftentimes untreated. And then they feel the stigma that providers project towards them or people in the community, and they feel they're some of the most marginalized people in our community because they're judged very harshly for what's going on. And here's a drawing that was made through this program, Young Women United, of how oftentimes these moms, they feel like they really are fighting for their lives if they are in a substance use disorder with opiates, and they feel like they are often viewed as a villain, and they really are in the fight of their life, and it's very difficult for them. So then all of this background, all this drama from the baby and the mommy will incite our personal feelings as providers. All of us as providers of care in New Mexico, I think all of us can recall a time when we were really burned by someone who has a substance use disorder in our practice, and they're very challenging to care for. And if it wasn't one of our patients, maybe it was someone in our family or our friends, or even someone we don't know who victimized us through crime that was related to addiction or substance use disorder. So all of this care can bring up these negative feelings towards these families and just put another barrier to providing best practices of care to these families. And it's important that we recognize where our feelings are about these issues and reflect and be aware of them as our first step to providing best practices for these babies. So coming back to best practices, we're going to talk about the care of neonates with prenatal opiate exposure. We're going to talk about their physiology and pharmacology, a little bit of the really important non-pharmacologic treatments, and what little we know about the long-term part. And we're going to sort of ask that you all think about the care of these babies in 3 stages. And this is going to help us in the future with our quality improvement projects. So dividing the care of these babies into 3 sections. First is going to be the identification of these infants in your practice. So this will be through history, where mom will disclose what she's using, but also through testing of the infants and the moms. The second section of care of these babies will be observation for symptoms of NAS. And I have in red there, not all infants will need treatment for withdrawal. So we do observation with scoring with the Finnegan scale, and we ask that babies be observed for around 96 hours, 72 to 96 hours inpatient, to see if they need treatment. So that's the second stage of care. Then the third stage would be treatment, and we're going to talk a little bit about oral morphine protocols, but really important, the non-pharmacologic treatments that go on. And Dr. Weingartner is going to take over the second section of this talk.
Okay, so we're going to kind of go through this section of the talk by talking through a case. So a baby that may be going through withdrawal. So this is a circumstance that a lot of you may deal with. So you're in the newborn nursery, you examine a patient, in this case, a baby girl named AJ. So AJ's mom is a 24-year-old G1. This is her first baby with heroin use during the beginning of her pregnancy. She did enroll in a substance abuse program and has been receiving buprenorphine daily since 25 weeks of gestation. Buprenorphine is Subutex or Suboxone is another way you guys may have heard that. To start off, this is just a nice little schematic kind of so you can think about the withdrawal from opioids and see that all of these things that we associate with neonatal abstinence syndrome, you know, the difficulties with sleep, irritability, increased appetite, hyper tension, tachycardia, tremors, vomiting, diarrhea, all of these things have a physiologic basis. So basically you've taken a baby that has had chronically stimulated opioid receptors throughout pregnancy in many cases. And then all of a sudden you take away the opioids. And so then you get you see the pathway right there, the superactivation, the adenyl cyclase, increased cyclic AMP, increased protein kinase, increased transcription factors, increased release of neurotransmitters. And so some neurotransmitters increase, some decrease, and they all lead to these physiologic things that we see. But it's important to know that these are neurologic basis for this withdrawal. So to just think about screening. So how do we identify infants that may be suffering from neonatal abstinence and that will be going through withdrawal? So there are, a couple of different extremes that you can go to. You can say every woman in labor should be screened with a urine drug screen. For obvious reasons, a lot of women do not feel comfortable with that, do not take kindly to that. And it's hard to do that for all women that are in labor. Another way to do it is if the provider taking care of that mom is concerned that for some reason they think that mom may have been using drugs, then you can screen those moms. That provides another problem, though, where you're starting to kind of profile moms, whether or not this mom looks like she would be a drug user, or in some cases, this mom, based on, for example, her socioeconomic status, would not be a drug user, whereas we know that problem does go throughout our whole society. So for the most part, although it does vary by facility, we try and have reasons for screening moms. So poor or no prenatal care is often an indicator of drug use. Certainly a history of maternal drug use should always make you think about that. And then anything that's going on with either the delivery or the baby that makes you think something else is going on that's not explained otherwise. So placental abruption, perinatal depression, neonatal seizures that don't have an otherwise obvious cause. And those are the moms that you would want to screen for NAS, or for, opioid use. Once the baby is born, if you have the concern for the baby, either because of a maternal drug screen or one of those factors, you can screen the baby's urine. You can also screen the baby's meconium or the cord. Short-term exposure of opioids is seen through the urine. Usually, depending on excretion, it's just the last few days that you're capturing, and you don't always have a good transfer of those drugs. So sometimes you may have a negative urine, even if there has been drug use. Meconium and cord gives you much longer term exposure. So if a mom has been habitually using something throughout pregnancy, you're likely to see that on the meconium or cord. Not so much if it's been an episodic thing. But again, for these babies, meconium and cord testing is very important because it does show you that chronic exposure to opioids. So back to AJ, born at 37 weeks via spontaneous vaginal delivery, good APGARs, birth weight of 2.1 kilos. So her mom denies alcohol or other illicit substances at this point, does admit to smoking, which has its own issues. But because of her prior history of drug use, urine drug screening was negative, except for buprenorphine, which is a prescribed maintenance medication that we know she was on. Just as an aside, many drug screens do not look for buprenorphine. So if you actually want to identify that use, you'll have to specifically ask for it. So the important thing is, A, that she's negative for everything else, and B, she's positive for what you expect her to be positive for. And one of the reasons that it is important what mom is on is studies have shown that buprenorphine as a maintenance medication for mothers often improves outcomes for babies in the sense that they tend to have lower rates of NAS, particularly NAS requiring treatment, less days of treatment required, and shorter hospital stays. And this is from the mother study, and that kind of shows you the difference between methadone and buprenorphine. And you can see that in the sense of length of stay, duration of pharmacologic treatment, and in the case of the total dose, highest dose of morphine that is required, that's all significantly improved with buprenorphine versus methadone. That said, each baby is an individual, and a baby on buprenorphine may have a very significant, or a mom on buprenorphine may have a baby with a significant withdrawal, and a mom on methadone, the baby may not require treatment at all. So that's why we go into a further scoring that we do. So back to AJ, you look at mom's chart, you discuss with her medical provider, her substance abuse counselor, and looking at her urine drug screen, everything else, that she can breastfeed. So she's on the one medication that she says she's on, no other illicit substances. So we let her breastfeed. On day of life 1, you notice that AJ is becoming a little more irritable. She's latching well, but is starting to spit up frequently. So kind of starting to show some signs that she might be going through withdrawal. So that's when we're moving into the observation period right now, and we've seen these signs of withdrawal, and so we're actually going to be scoring the baby. The modified Finnegan scale is the most widely used scale. It's a scale of 21 symptoms that we often see in opioid-exposed infants. It identifies not only the presence of these symptoms, but also the severity of these symptoms, and gives us a score. That score is not a snapshot in time. It is a score of how the baby has been doing over the past, say, 2 to 4 hours. And that's something that we can use to more objectively evaluate the degree of withdrawal a baby is going through. So these, the Finnegan scale kind of we can divide it up into 3 different kinds of clinical presentations. So you have CNS disturbances. So these are the babies that aren't sleeping well, that are spending a lot of time awake, they're crying, they're hyperactive, they're hypertonic, they have tremors, they're very agitated. In the most extreme case, they can have seizures. Then you have the metabolic vasomotor respiratory disturbances. So those are the babies that are sweating, they may have high temperatures, sneezing and nasal stuffiness, yawning, that modeling of the skin, tachypnea. And then, of course, the gastrointestinal disturbances. And so this is where you see the babies with diarrhea, with vomiting, babies that may be really trying to suck and maybe excessively sucking, but aren't doing a good job of feeding and organizing themselves. So they may actually be losing weight or not doing well. So in this case, you start scoring AJ. So you review scores, and again, you're going to get scores every 2 to 4 hours. Most people do it about every 3 hours. And then you look at the trend of the scores. So certainly if the scores are increasing, if they are getting worse, and then you also are looking at kind of that absolute objective score. So kind of 8 is a score where we look at more of a concern that the baby is withdrawing in a way that will require pharmacologic treatment. So this baby, last 3 scores, 8, 10, and 9. So at that point, we have decided to start oral morphine. We'll letting mom know of that. And this is an important thing here, is that in this case, mom is careful when you tell her baby needs medication. And this is often true. Moms, as we were talking about, they understand what's going on. They often themselves understand what withdrawal is like. So they know what their baby is going through. In some cases, moms have been told that if they are on buprenorphine, their baby won't withdraw. And so they're surprised when their baby requires morphine anyway. So this is a time to be supportive of mom and let her know what's going on at all times. So threshold for pharmacologic treatment, like I said before, 8 is kind of that magic number. So if you have 3 consecutive scores of 8 or more, you would want to start morphine. Or if you have 2 to 3 scores that add up to 24. So you may have a 6, but then 2 10s, and then you would start morphine. You may have a 12 and a 13, you would start morphine. And you have to observe those babies for a significant period of time, at least 72 hours, recommended 96 hours, and sometimes, depending if mom has been maintained on long-acting opioids like methadone, we may even want to observe the baby for longer to make sure that they're truly not withdrawing. Once they reach that point of kind of that magic number of 8, that's when we start thinking about pharmacologic treatment. So the state of New Mexico and the different hospitals in New Mexico have a variety of approaches. So we're just going to kind of quickly go through a couple of ways that it's done. There is no unified way that anyone has decided that this is the way we should be treating these babies. This is the dose we should be giving based on But this is just a couple of ideas. This is one of the things we'll be talking about a little bit later that we would like to codify a little bit more so that it's easier for people across the state to know what we should be doing. At UNM, there's several different protocols in use. The important thing about the morphine protocol at UNM is it's not based on weight, so it's just based on the score. If mom is maintained on buprenorphine, the baby will get oral morphine. Depending on what else the mom may be on, they may be put on something else. Right now, we're just going to talk about morphine. So this is one example based on the score. Again, 8 is that kind of magic number. Once you get above that, then you start giving the morphine. These are all PO doses. And in this protocol, it's not based on weight, okay? Just as an aside, morphine is what we're really talking about here, and that's the first line treatment. And for most babies, that's all that's needed. There are other medicines that can be used as well, more as adjuncts rather than in place of morphine. So if you've reached a high morphine dose, don't feel comfortable going higher, or if the morphine dose is having significant side effects, you may want to consider clonidine or phenobarbital. In general, you probably would be considering transfer to a higher level of care as well if you were requiring other medicines other than morphine. We will just stick to morphine right now, though. This is another protocol for treatment with morphine. This is what's used at Presbyterian Hospital. Again, this is, when you get to that dose or that score of 8, 3 consecutive scores or an average over 3, then you would start. Again, that 0.04 is kind of the number that's used. This is actually wrong. It's not per dose. It's actually per kilo per dose that's used at Presbyterian. And that's a difference as well. And it's not that one is necessarily right or the other is wrong. It's just different ways of doing things. And then you increase the dose based on what scores are doing at that point. Maximum dose is 0.14 per kilo. That is the point when you would start thinking about transferring and adding other medicines in. Then weaning is kind of, clearly the opposite. When scores are starting to come down, then you start decreasing the dose. When you get to a minimum dose at Presbyterian is 0.02 per kilo, then you start weaning the interval. And then once you are actually off the morphine completely, you're going to need to continue to score the baby and observe the baby for a minimum of 24 to 48 hours, depending on how significant the baby's withdrawal and how long their course was. You may want to observe that baby for even 4 to 5 days to make sure that they're okay. So back to AJ. AJ is able to undergo her first morphine wean on day of life 4. She is rooming in with mom. Now this is important. We focus on the pharmacologic treatment of NAS because we know that if a baby requires morphine for those opioid receptors, the baby requires it. But there are a lot of non-pharmacologic treatments as well. And those treatments can not only improve the baby's outcome as far as decreasing total dose of morphine or length of morphine treatment required, sometimes it can actually prevent the need for morphine at all. So the number one thing that we can do for these babies is skin to skin. It's calming for the baby. It helps treat the baby's withdrawal. It promotes bonding with the mother. And this is really, really important as well, because if we can promote that bonding with the mother, we are hopefully improving outcomes not only throughout this hospitalization, but after hospitalization as well. We're teaching mom how she can actually take care of her child and calm her child without the need for pharmacologic treatment. Going along with that is breastfeeding. Breastfeeding, again, promotes bonding. We know breastfeeding for a variety of reasons is really important and good for babies. If the mom is on methadone or buprenorphine and isn't a treatment program, we encourage breastfeeding. Certainly, if there are illicit substances, we tend to discourage that. But if mom is in a program and doing what she is supposed to be doing in her program, we recommend breastfeeding. So not only for those, the calming and the bonding, but also there's going to be some transfer of the opioid through the breast milk, and that is also going to help ease infant withdrawal. So we'll be getting some technically pharmacologic treatment, but it will be treatment that doesn't require additional morphine dosing. That said, you also need to really talk to the mom and educate her on not stopping breastfeeding abruptly, because that might send a baby into withdrawal. Certainly, that can be a problem after the baby goes home, and as milk supply may taper off. You need to let mom know about that. Other non-pharmacologic treatments of NAS. So these are the 5 S's. It's one way of thinking about a way of calming babies. So swaddling creates a barrier for the baby, prevents flailing. Side or stomach position also prevents flailing, keeps the baby comfortable. Shushing mimics the sound of the womb. We've all seen babies that like the swinging and those fast back and forth movements. And then really one of the important things is sucking. So we see these babies that are frantic and they want to suck all of the time, but they're not effective. They may start throwing up because they don't necessarily need the nutrition. They need that sucking for that soothing, the non-nutritive soothing. So to really work on when is a pacifier appropriate for a baby versus just starting to give a bottle every time the baby is upset. So all of these are really, really important. And the thing about all of these is you can teach mom to do all of these things. If you're able to have mom room in with the baby, that's even better. It can significantly improve the baby's course. So AJ, scores are done every 3 to 4 hours. Like we said, that's you kind of do those scores over a period of time. You try and cluster care. So when the baby wakes up to feed, or every 3 hours when you're giving the morphine, that's when you're changing the diaper, that's when you're doing whatever else you need to do for the baby so that you're not waking the baby up or disturbing their good time. Okay, so at this point, AJ is weaning on her morphine. She's now feeding well and is starting to gain weight. So our goals. The primary goal, of course, is to decrease the severity of withdrawal for the baby as well as the length of treatment for the baby. One of the important things to really think about, though, is there is the hospitalization when we are trying to treat the withdrawal, but then we also want to think about what's going to happen to the baby when they go home. And so if we're teaching mom all of these non-pharmacologic interventions, if we're allowing her to room in, if we're allowing her to breastfeed, if we're making her the primary caregiver for her infant, that's likely to help increase or improve the baby's outcomes when she goes home. So AJ, on day of life 16, she's given her last dose of morphine. She's gaining an average of 25 grams a day. She's eating well. Mom has continued to be an active participant in her cares, is seeing her counselor, taking her buprenorphine, is doing well. So AJ is discharged home with her. So as far as a hospitalization goes, it's a success. But what about our long-term outcomes? Unfortunately, we have very limited data about this. And part of the problem is that for these babies that have gone through withdrawal, many of those babies have ongoing environmental risks. And it's hard to differentiate in many cases whether it's those ongoing environmental risks or whether it's the neonatal abstinence syndrome that is responsible for the outcomes. Okay, so almost all studies will show significantly lower scores on all assessments for infants with prenatal exposure. But we also know that babies have a tremendous ability to compensate, and their brains have tremendous neuroplasticity. And so theoretically, if we improve those environments that the babies are going home to, we can not only differentiate between those two risks, we can also improve outcomes just based on the NAS itself. Part of that improvement of environmental risk is engaging that mom early and often in the infant's hospitalization. So that is not just good for the mom, that is good for the baby's outcome. And that's a really important thing, is that the baby is our patient. The mom is not our patient, but treating the mom non-judgmentally, allowing her to provide care, and encouraging her to be as significant a part in her baby's recovery as possible will likely improve that baby's outcomes.
All right, I'm going to talk a little bit about the statewide initiative we're working on to do best practices for these babies' care. So we have a perinatal collaborative in New Mexico, which is an initiative that's started by the CDC, which, so there's networks across the nation of perinatal care providers and public health professionals who are all working to improve pregnancy outcomes for women and newborns. And so this is the group that we have started, and we're going to try to do best practices for these little babies as one of the projects of the Perinatal Collaborative. We're going to collaborate with the Envision group, who's going to help us do a systematic quality improvement project for groups who are interested in this project. And we'll be able to offer maintenance of certification for providers who get involved in this quality initiative. And so we're going to be collaborating cross-institutionally with at least UNM and Presbyterian, and hopefully with a number of other institutions. So the pieces of this initiative are, again, we're going to agree on standardization of care of these babies. So we'll likely have a simple morphine protocol that we'll all use. Then we want to provide support to the providers who want to feel competence and get in the care of these babies, which will include training both on site and then webinar or telehealth sessions. We want to have mini sabbaticals for nursing staff and for support staff, as well as for providers to come to the centers, especially UNM or Presbyterian, to observe and discuss care of these babies with the providers in our nurseries and NICUs. And both pediatric and family and community medicine boards maintenance and certification will be offered along with continuing medical education and nursing continuing education through this project. So again, I want to come back to those 3 stages of care for these babies. So we want to have groups who get really comfortable with identification of these infants in community hospital, and then also get comfortable with the observation and scoring piece at their home institution. And if institutions are interested in providing the treatment of oral morphine, we want to support the whole group who will be involved. That would be the pharmacists, the techs, the nurses, and the physicians who would be providing this care. And also we'll have discussions at each point in the stage of baby care at identification, observation, and treatment of when a transport to the higher level of care would be appropriate. So care of these babies is really hard, so let's do it together. We want to do it well and help everyone feel comfortable with these little babies because it's worth it, because they're an important, vulnerable part of our community who deserve our attention and care. So many of you at your institution should probably received a survey from the Perinatal Collaborative about the care of these babies at your institution. If you have it sitting on your desk, fill it out and send it in, or send me an email, or contact us through the Envision group as well. And so we can start planning on this project. The next step for the statewide initiative is Dr. Weingardner and I will be at the Wilder Lectures at the end of this month, and we'll talk more about this. We're also, if anybody else would like to find out more about the Perinatal Collaborative, please email me. I can connect you to them as well. And then we'd like to make ourselves available for questions anybody has right now. No.
So a trick, for telehealth is the clock with the second hand when you ask a question, wait 30 to 60 seconds.
Oh, okay.
So while we're waiting, I have a question for you.
Yes.
So you answered one of them, but just to clarify, do you always watch for 96 hours for any mom who you think has used a substance you're concerned about?
So
Do you always watch the baby? I mean, I guess is
I think
my
it
question.
really depends on if the mom, not so much the concern, but if you have a positive urine drug screen for either the mom or the baby, then
Okay.
yes, I would say in general we do.
We do have, Dr. Mason asks, will part of the collaborative include information for outpatient providers?
So the outpatient piece is kind of a whole separate section of care for these babies. So initially, we're going to start with the inpatient care of the neonates. Outpatient care of babies who have prenatal exposure is also really important and requires a whole different set of skills and expertise. So at the UNM Focus Clinic is one of the models of collaborative care for these babies, where we have developmental specialists and case managers and psychiatric and psychological support for the whole family. So it's there's a number of disciplines. It's cross-disciplinary. It's very intensive. Families choose to engage in this program, and they get home visits from their developmental specialists, or sometimes twice a week, sometimes more. So they have to be ready to have someone come into their home and visit them. And it's at the Focus program, we have a group of families who are very engaged and very supported. They're some of the more vulnerable families we have in our community, and it's really lovely for them. I mean, it feels great because there's this very tight relationship with the providers and with these families, but it is very resource intensive. So the outpatient care of these babies, I think, will be another step in this whole program, because obviously there's way more of these babies. The population is much bigger in the outpatient setting, and they do have special care demands. So yes.
But I would say that even if you're not able to provide all of that to these families, which would be the ideal,
Yes.
But knowing what we know about these babies is to get them into early intervention and into developmental follow-up. And I think that's really important, and that's something that you can do even without all of the other specialized help. Again, with early intervention, you have to have a family that's willing to allow somebody to come into their home. But if they're in that state, that's one of the best things that you can start off by doing for the baby.
Thank you.
So this is Kirsten Bennett off screen. I asked the other question. I should have introduced myself. So interesting that you bring that up, because some of the initiatives that we already do at Envision tie into the outpatient piece. So when you guys were talking about what support you might give for providers that choose to work with you, if they have people in their community who are more on the community home outpatient side, that may be some of the extra education that you provide via a webinar support, and how we would maybe tie them into our developmental screening initiative, potentially using a different screening tool like the SWIC that looks at family well-being, picks up some of those environmental risk factors that you were talking about. So that's a possibility.
Yep.
Even though it's not part of your current plan, we might be able to
Right.
hook them into
That's
something
right.
else.
Yes. So
Exactly.
yeah, early intervention and developmental support are the foundation of care for these babies in the community. And I would like to also come back to some things we talked about the compassionate care. So what we'd really like is for outpatient providers to provide a safe place for these families to come and to make families feel that they can come and seek care for their child and have a relationship with their provider that is compassionate and non-judgmental, so that they can have a medical home where we can start providing these services. So that's a big piece, is to have an open door for these families.
Wonderful. Are there any other questions? Dr. Mason just said thank you, that she really appreciated you sharing your expertise and taking the time to help improve our education.
Well, thanks for inviting us. We appreciate it.
Yes, it was wonderful. Well, great. Thank you again. If anybody else is out there and would like to announce themselves in the chat box for their CME, or if you're having a hard time trying to figure out the chat box, you can go ahead and just email me, Michelle Weidner, and my email's everywhere, so please feel free to shoot me an email and let me know that you were on. Thank you again very, very much. Thank you guys so much for doing this. And like I said, if you have any other questions or follow-up questions that you would like to send, you can go ahead and send it directly to Dr. Pratt-Chavez, or you can send it to me and I can go ahead and filter that on to her and Dr. Weingartner. So thank you, everybody, and have a good afternoon.